we have some people to share experiences from their experiences in acute and mental health settings today. And then we've got some time for the discussion and questions after that, if that's okay. So without any kind of further ado, if I can hand over to Mike to get us started.
Not a problem, John. Perfect. Right then, guys, my name is Mike Smith. I'm the Healthy Hospitals Programme Manager at Rotherham. And if everyone very kindly could keep on mute while we're doing the presentations. And as Joanna said, there'll be plenty of opportunity for questions at the end. So I have a slide deck to work through. We'll work through that. And as I say, questions, opportunities towards the end. So, Joanna, can I just check that that's come through okay?
It has, yes.
Perfect. Okay, so welcome everybody. Thank you for coming to this forum. My name is Mike Smith. I'm a Healthy Hospitals Programme Manager at the Rotherham NHS Foundation Trust. I've been asked to come on this forum today to share our experience of delivering tobacco treatment services. This is what has worked at Rotherham. This may not be applicable to everyone. You may be at a different point in your journey of delivery of these services. But if you can take one little nugget from it, one little take-home message that benefits your service, then all the better. Okay. So we are really fortunate in Rotherham to be part of the South Yorkshire and Bassetlaw QUIT programme, with our main funders being Yorkshire Cancer Research. We are in our third year of delivery now. We're relatively well established. Are we all right just to mute microphones if that's okay? We are well established as a service. So I'm a respiratory physio by background. I'm not a medic, I'm not a nurse. So please excuse when I talk about the prescribing elements of this, but this is what has been worked up with our medical director and our chief pharmacist, who have been absolutely pivotal in the delivery of this. So as you see pictured there, this is our amazing tobacco treatment team. So we have Bev, our nursing lead for the tobacco treatment services, and 5 amazing tobacco treatment advisors in their distinctive teal uniforms, a colour that is consistent across the trust and with our branding. For context, our trust is based at a single hospital site and has around about 370 beds, and we have 4.4 tobacco treatment advisors to deliver a 7-day service. Okay, so we have an impact statement at Rotherham that we will provide these services with a view to reduction in the smoking prevalence of Rotherham and the associated healthcare burden. In the most recent OHID data, our smoking prevalence in Rotherham is 14%, which is higher than the national and the regional average, thus the investment in it. We also have higher prevalence of smoking-related admissions and deaths. So we have an agreed ICB target, which is a slightly complex one, but it is 45% of all smokers with a length of stay greater than or equal to 1, a prescribed NRT within 24 hours of admission. So the gold standard absolutely is within 2 hours, and this agreed target is within 24. So it's multifactorial. So to break it down a little bit, 45% is the target because there is patient choice in there. What we are not doing is prescribing blind or prescribing by default for any identified smoker. They must agree to that prescription and provision currently. Length of stay greater than or equal to 1. What that does, that removes our day cases and inpatient observations. Those patients are engaged in a slightly different way, but they are not included in this metric. And within 24 hours of admission, this is from the point of decision to admit to the actual prescription being completed. So in January, when we inherited this metric, we wanted to know what our baseline was. And our baseline, quite scarily, was only 15%. So we had an awful lot of work to do to get towards that 45% target. So how did we do it? We've mentioned about quality improvement, and I'm a CUSA associate. If anyone's not done the CUSA program, I would highly recommend it, and I would recommend further still going on to be an associate and deliver it. And we use some quality improvement initiatives and tools to kind of break down this target. So the first thing that we did was we did process mapping, and we looked at our previous state, and it was a state. All right. And it is deliberately obtuse, this diagram, because this is what it felt like to work in. So we would identify smokers, and that was brilliantly done by our nurses within their screening documentation. but we actually received it, the tobacco treatment team, via an overnight data report. So we were assessing people that were identified yesterday. Already the clock had been ticking, so clearly dysfunctional in that way. We would attend for our assessments, do our recommendation, and then we would obviously have to seek a prescriber to support that recommendation. And I jest you not, that would include chasing a prescriber down the corridor with an open laptop saying, can you please prescribe and support this? This caused obvious delays. The nurse would then order it via pharmacy because we had no ward stock of NRT. It wasn't routinely kept on the wards. And as you can imagine, NRT was very often seen as a routine request, so it could even be next working day. Inevitably, your patient would then be outside smoking because 24, 48 hours have passed and we've still not got any support. Obviously less than ideal. Finally, when the NRT arrived on the ward, it would be administered by the nurse. This pathway could take anywhere from 48 to 72 hours. So there was no way we were going to consistently achieve our target with this dysfunctional setup. So another tool from quality improvement is driver diagrams. And if you've not seen one before, just to describe it briefly, on the left-hand side, we have our overall aim. Then it is broken down into primary, secondary drivers, and then the change initiatives that contribute to those. And there's 3 elements that I'd like to highlight to you today, as these are things we've put in place since January of this year. The first is our live screening report, which replaces that overnight data feed. So that is effectively an instant referral once we know about a smoker. We then looked at our ward NRT stock, and we saw that as improving our acceptance for NRT because we were able to provide it there and then and go through and provide the education with the product. And then also our locally agreed protocols. So Joanna alluded to it with PGDs, locally agreed protocols, homely remedies. We have elected to pursue a locally agreed protocol, and I'll take you through that and how it's contributed to the improvements in the trust. So what is a locally agreed protocol? So this is to allow us to directly add NRT to the prescription chart, and that be done by a non-prescriber. Okay, so that's the change. A non-prescriber can actually prescribe these medications. Why are we doing it? So that we can get to provision quicker, we can meet that target that I've aforementioned, reduce the burden on our prescribers for what is a simple medication request in most instances, and we improve patient care. It's targeted towards our nurses, midwives, and our NCSCT practitioners, i.e. our tobacco treatment advisors. And this is why it's a LAP, because it's being extended beyond just our registered nurses, AHPs. And actually, we could go a step further and start considering this with our Stop Smoking champions in healthcare assistant roles that are appropriately placed, much more flexible. And this was worked up with our chief pharmacist and our medical director, who had a real position of comfort with the provision of NRT. It was an open conversation of how can we utilize this better. When would we use it? At initial assessments, but we exclude patients with a cardiac event within the last 4 weeks. And it goes hand in hand with we don't utilize it in high dependency or coronary care areas. This is not that these patients can't get NRT. It's just that NRT is a consultant-led decision in those instances. Okay. So this is our new process, the new state, and it's a much cleaner, more linear pathway. So we now identify our smokers through nurses screening, and it's an instant referral to our tobacco treatment advisors. They attend for assessment, make the NRT recommendation, and they can now utilize the locally agreed protocol, which they're signed off against, to prescribe that NRT directly. And that actually includes an ongoing provision. It's not just 24-hour provision to bridge to a medic review. It's an ongoing provision and the inclusion of TTO request if appropriate. Then our nurse can administer it, having drawn that from the ward NRT stock. So administration still sits with the nurse. What we didn't want within the organisation was multiple individuals contributing or inputting to that administration platform. That still remains with the nurse. But in real terms, this can now be delivered in a single visit. We still have that green deviation above, whereby a medical view can be requested, a consultant support of that decision for those with known cardiac instability, events within the last 4 weeks, or if there's any element of uncertainty that means we're not comfortable utilising the lab. Within the trust, since we've endorsed the LAP and utilised the LAP, we've had over 500 NRT prescriptions completed via the LAP. We are yet to have an incident as a result. We are yet to have one challenged by the medical team. It's approximately 90% of our top to lead prescribing goes down that locally agreed pathway now. So here's some data to demonstrate the impact that this has had. So what this is showing is prescriptions by length of stay. And the top line is prescriptions at any point during the admission. The bottom line is prescriptions that were achieved within 24 hours. So our baseline, as I previously mentioned, was 15% were achieved within 24 hours, which was a fairly low starting point. Purely by starting to concentrate on this metric, we saw improvements. Our live reporting functions certainly helped increase NRT provision generally, but the bit I'd like to direct you to is between May and June when we fully introduced the LAP, and we saw that step change and vast increase in prescriptions within 24 hours. That's because our TOPTers were doing it, our tobacco treatment advisors. And we narrowed the gaps so much so that the vast majority of our prescribing was done within that first 24 hours. We're now at a position in August and September where over 50% of all smokers that come into the trust accept NRT, be that for a quit attempt or temporary abstinence. So a really strong position. Unfortunately, in August, September, we've had a reduction in our top-tier tobacco advisor staffing and recruitment. So we've seen a fall in their input, and that's shown a fall in our 24-hour provisions, which does show how dependent we are currently on the tobacco treatment team. So I go back to Joanna and Matt's messages about the importance of cultural change and starting to embed this within the clinical teams so that you get that robustness within the service. The next graphic, the orange line is the same as the previous slide, so NRT at any point, but I've put on the top there for our specialist assessments in green, specialist assessment being defined as a face-to-face assessment whereby a NRT recommendation has been made, whether or not they accept it. And the yellow line is a quit attempt by way of commitment to a quit and an ongoing community referral post-discharge. And what we can see here, there's a really interesting narrative around that staffing reduction that we had. We had to stand down weekends. And what we saw was a reduction in our specialist assessments. Some people were being discharged before we'd seen them face-to-face. And that line very closely relates to the number of people that are going on for an ongoing quit attempt. And for me, that really shows the value of that face-to-face engagement, behavioural support, relationship building that you can only really get from a one-to-one, face-to-face engaged conversation. Because actually we saw that fall in onward referrals, despite the fact NRT prescribing within the trust continued to steadily increase. So a really interesting narrative around that. But what do people think about it? The medics absolutely love it because you're not chasing them down the corridor in the same way, and it's less burden for those simple cases, the vast majority of which we are classifying as those simple cases, around about 90%. The nurses, it's a much easier, cleaner, linear pathway, and the fact that we can, bottom line, get the products to the patients quicker, they're happier because they've got less agitated patients on the ward. I love this one from the patient, this chap, way quicker than I got them last time. That obviously shows we didn't get him to quit last time. I dug into this and he was a temporary abstinence last time, had a readmission, and he's now a quit attempt and has gone on to the community to quit. A real importance there that actually temporary abstinence plays a part in that behavioural change wheel, and you might not get them this time, but you might get them next. And the final one is our advisors. So our advisors have felt really empowered by this. They are truly the tobacco treatment specialists now, and they can act upon their recommendations. Our advisors certainly would not be without it. So what are the next steps for us? We are asking our advisors to work a little bit differently. So I think it's only right that we review that job description and take it back to desktop review, HR review with a view to job matching panel, because it may impact where they sit within their banding. They are a band 3 currently, and we await the outcome of that job matching panel. We need to increase our number of individuals using the lab, and we're going to do targeted promotion in A&E and admission unit for those non-prescribers that could be utilising this, so we reduce the dependence on the tobacco treatment team. We're also looking at enhanced data insights so that we can better inform our targeted training and support areas by prescription rates, etc., by area, by pathway. So there's a lot of work to do with this to embed that cultural change and get people utilising this beyond our advisors. But having utilised it in our advisors and the changes that I've mentioned, we've seen a real step increase, and we are setting the tone currently. And it's about now embedding that cultural change moving forward. Okay.
Brilliant. Thanks, Mike. That's really great. And I can see that there's already some questions coming through. If I can ask you to put your questions in the Mentimeter, there is a new code that's been put in the chat. And what I'm going to do is I'd like to introduce Clementine Bunce now from the National Collaborating Centre for Mental Health. And as I say, if you can keep putting your questions in, and we'll get round to them once we finish with the presentations. Thanks.
Hi everyone. Thanks Joanna, and thank you Mike for that presentation and for sharing your current QI work. So as Joanna mentioned there, my name is Clementine. I'm a quality improvement coach from the National Collaborating Centre for Mental Health, which sits within the Royal College of Psychiatrists. And currently we are working on our QITS collaborative, which stands for Quality Improvement in Tobacco Treatment. And the aim of this work is to increase the number of patients in mental health settings who smoke, who engage in a meaningful smoking cessation treatment. So some of my teams are in the early stages of testing their change ideas, some of which do relate to the speediness of administering NRT. So, for example, improving links with pharmacy teams, which Joanna emphasised the importance of earlier, and also sort of around staff training on prescribing. So we hope to share the progress of some of these change ideas and other areas of work as this programme continues into next year. So on that note, so there are currently teams working on round one, as I mentioned, and their work will continue over into 2024. But we also have opened registration for new teams to sign up to work on this quality improvement collaborative. And this will officially launch in January 23rd of next year. So our goal is to work with all mental health trusts, but there's a few that we're yet to hear from. So what I would like to do, if possible, is to include the contact details for myself and the QUIT team, and also the registration form. So we're currently missing registrations from Black Country Healthcare, Cornwall Partnership, Herefordshire and Worcestershire, Humber Teaching NHS Foundation Trust, Kent and Medway, North London Mental Health Partnership, North Staffordshire Combined Healthcare, Pennine Care, South West London and St George's, Southern Health and West London. So if representatives from any of those trusts are here and you want to get a little bit more information or ask questions, please get in touch. Or if you know anybody in those trusts, please pass on details if they don't have information or would like to know anything more about the work. So thank you in advance for that. So I'm really happy to hand over now to Agechi. Agechi is one of our current round one teams on the QUIT programme, and they're doing some really amazing work. But Agechi now is going to outline for you the sort of the current landscape in the mental health services around the speediness of NRT. So Agechi, it's over to you.
Thank you, Clem. That's a lovely introduction, and I highly recommend people to join the QI Collaborative if you can, because it will showcase and you'll learn from different trusts as well. So thanks, Clem, and also thank you, Mike, for the wonderful presentation. I'm just going to share my screen. Can everyone see my screen? Can everyone see the slides?
Not yet.
Can you see them now?
I can't. No, it says that you've started screen sharing, but it's blank.
Oh dear. I've envisaged this happening. Okay, let me try again.
Don't worry, we'll find a way.
Yes. Can you see now?
No, do you want to email them to me and I'll share them? I'll get you.
Perfect. Okay, I'll do that. Sorry.
And while we're doing that, Clementine, would you like to put your email in the chat? Because I can think there are some trusts who are either will contact you or will contact their colleagues. So do that in the meantime. Great way to.
Absolutely.
There's Black Country there and someone from Worcester who might contact their colleagues in Hereford. So that's all good. And
I've noticed a few questions just in the chat relating to Mike's presentation as to whether we can share the protocol. And I'm not wanting to talk for Mike. Mike can please feel free. But I did think, Mike, you had said that we would be able to share them and put them on futures.
Yeah, absolutely fine. It'll go on futures. I will be honest, I've not put anything on there before, so I will find out how to do. But I'll share that with the protocol, which is all signed off and approved. Please don't rip it apart, but utilize it as it benefits you. I've been reading, while we're sorting the technical bits, I've been reading all the questions. There's quite a few. So just to go through a couple, does that make sense to go through them now, Joanna? Just a couple while we're waiting.
Yes, just while we're waiting. I'll wait for Getchi to give us the thumbs up when she's ready, or Olivia when they're ready. But if you want to answer, there is a couple there. Yep.
Cool. I can answer a few. So apologies, I used an acronym. It's QSA. Quality Service Improvement and Redesign is the quality improvement program that I'm an associate on. So QSA. With regard to follow-ups, we provide follow-up calls, and actually it's a bit of a deviation from the normal pathway. We invest our follow-up call time in our temporary abstinence patients with a view to trying to convert them to a quit on discharge. All our patients are pre-consented to a quit when they're in hospital. So we automatically refer them to the community provider on discharge if they pre-consented to that. We are only able to do that because we have an amazing community service that get on top of them within a week. If there was more of a delay, we wouldn't have that luxury. So that's a couple of questions answered.
Brilliant. Thanks, Mike. Olivia, do you have the presentation, or?
I do now. I'll share that and let's do that now. Sure
Sorry about that.
Yeah, no worries. It's the kind of thing that. Maybe this is the right version.
I hope so too.
Yeah. I think because we looked at that this morning, didn't we? Right.
Yeah.
It's not full screen, so there we go. Should be full screen now. I shall turn myself off. And
okay. Thank you very much, Olivia, for assisting in technical difficulties. So, hi everyone. I'm Agechi. I'm the Trust and Forensic Lead for Tobacco Dependency at East London Foundation Trust. So I'm just going to talk. We are an acute mental health trust. So we cover inpatient forensic settings, both low and medium secure, and also in the community services across the different boroughs and directorates. So we started the service in 2019. So you can see myself, Andrew, and Christoph. We covered Bedford and Luton, City and Hackney, Newham, Tower Hamlets, forensics as well. At the moment, we have 10 advisors. So you can imagine we expanded last year from 3 advisors to 10. And in that process, over the last 12 months, we've assessed over 1,688 patients. So my lovely team is in the right. You can see this was taken from one of our away days during the summer. So next slide, please. So at the moment, we use a pathway that is the prescriber model, which some trusts are very familiar with. And there's been a lot of discussions around how to access and administer and give NRT. So at the moment, we don't use the homely remedy protocol. So ELF is still a medical prescribing model. So it's either prescribed by the doctors or independent prescribers, so nurses as well as pharmacists, which we are working closely with. We do have quite a number of nurse prescribers across the trust already, and some members in my team are also registered nurses that are, undergoing their prescriber course requisites first before attending the course. The NRT dosage, again, is reviewed by the ward pharmacist. And this is also in tandem with the doctors as well, the MDT. And this is based off the advice from our team. So our team, our advisors are all level 2 trained. And they also assist in any of the the decisions with the pharmacists and the doctors in line with other additional medications that our service users will be on. As you know, within the mental health setting, they are on a plethora of medications at this moment in time. Next slide, please. So this is our service pathway. So you can imagine on admission, we offer very brief advice to all new admissions, and this is recorded on the lifestyle assessment form on Rio. All smokers.
Actually, can I just interrupt very quickly? I think we've got it might. I was wondering whether we could keep things as brief as possible because we need to leave enough questions at the end. So maybe we just pick out the key points and we'll just move through as quickly as possible.
That's fine. Thanks, Olivia. So we ideally all our smokers should be offered NRT within half an hour, but you can imagine in that setting it can also be extended to even 2 hours or 24 hours, which is normally administered, and the staff on the wards will refer to our team. Following that, they'll have an inpatient follow-up review, and also there'll be 12 weeks discharge. So we used to have a 6-week post-discharge in place, but at the moment we refer straight into our 12 weeks because we saw there was a downturn of service users entering the service. And if they need further support, service users can be referred to the local authority as well. We do have service users who are using vapes at the moment and also NRT as well. Next slide, please. So the timeliness, again, it's estimated, we have 100% of our service users offered NRT and 50% receive NRT within 24 hours. The data is quite anecdotal at the moment, so we are building a system in place. Some directorates are performing better than others, and this is due to, conversations, ongoing revolving conversations, but we find that we will do an audit to monitor this moving forward as well. So here are some of the barriers and enablers. So again, understaffing has had a significant impact on high staff turnover. So a training schedule has to take this into account. And also lack of staff confidence is something that we're seeing as a theme. Even though they've had the training on numerous occasions, they still don't feel confident to have this conversation. So this is where competency will be assessed moving forward. Again, staff may perceive smoking as a way to reduce issues on the ward, challenges, and de-escalate situations dependent on the mental state of the service user. So again, that culture of turning a blind eye, and also high level of smoking amongst staff, especially since the pandemic. But the good thing about the flip side of this is longer inpatient stay. So our advisors have a great opportunity to build a rapport and also intervene earlier. And there's also a greater control of patient choices as well when they are under section. Next slide, please. Again, we looked more at the culture, which was very important in us influencing that change. So I've updated the smoke-free policy by combining it into one. I also deliver bi-monthly training at level 2 for all service users can attend, as well as staff of different staffing groups. There's also champions on the ward across the different directorates. So there's that checklist, having a drop-in session for them to feel supported as well. The best thing about it, we use the QI methodology where we engage staff to be involved in updating the policy as well. And we also support staff during this process as well who need support giving up. Next slide, please. So again, 25% of our patients have chosen to use NRT as a combination solely, and this is across trust-wide. Again, I've touched upon some areas, some directorates are doing better than others, but the universal consensus is, nearly 3/4 of our patients are vaping and using NRT concurrently. Next slide, please. Again, we've seen violence and aggression reduce across the trust from Datex that our advisors access the Datex reports and investigate any issues on the ward. And this is largely due to having a treatment care plan in place. We've also supported staff quit since 2021. So over 30 staff have quit with our service. And delivering training, again, is over 370 staff members from all staffing groups have attended. So it's not restricted just to clinical. We have social staff, AHPs attend the training as well. And you can imagine our trust is quite large. So there's over 6,000 staff members in our trust. So for the future, we've seen that vaping is more popular amongst our SMI population, and we're working with stakeholders to be part of the stop scheme, as long as it's compliant with our service users who we get involved in making decisions on what's safe for them to use, and also we don't want them to start using illicit vapes or tobacco. Okay, I think that's it from me. It's a little spiel there, but again, we want. Yeah, sorry, Olivia. Do you want
No,
to come
sorry,
in?
I was just going to say
Oh,
thanks, Agechi. I know
yeah.
Matt had gone through those last couple of slides there, just in terms of the
Yes.
the discussion in that. So probably it's maybe worth us kind of moving on. I know we've got limited time. But I think for me, it's really positive to see the impacts, from both kind of what Mike was talking about in the acute setting, but also from the mental health setting, of where we can have this really QI approach to kind of improving the treatment and the management of nicotine withdrawal. One of the kind of, there's been a couple of questions that's come through around what's made the biggest difference to kind of getting these in place. Whether is it kind of having the medical director on board, is it the pharmacist having the pharmacy on board, or whether you've had any kind of pushbacks from maybe medical directors or pharmacists. Agechi?
Yeah, so initially there was some pushback, you can imagine. Staff, a lot of the questions were around, are we taking their right away? This is the only thing they look forward to, all the usual perceptions around that. But eventually what I found was embedding it with other MDTs. So having the physical health team on board, the medical directors who are really keen, and also a public health team. If you have a public health team within your trust, it's really good to network and look at the core 20+5, achieving those objectives, especially with SMI. It's a big thing. We know from a clinical point of view the impacts clozapine and olanzapine and other medication have. So this is something that was ultimately a selling point, and not looking at it as a lifestyle choice, but rather as a chronic relapse in addiction, that they would need support and even a harm reduction point. I also saw a message around access to inhalators. So we have a similar problem in our forensic secure units where inhalators are restricted, but they do have access to other NRT, and this is due to misuse of the inhalator. But if they're in the community, that they have access to it.
Brilliant, thanks. Mike, did you want to add anything?
Yeah, I'd say that our chief pharmacist was absolutely pivotal to this, and I refer to it as a position of comfort. When they started, it was, okay, tell me what you need, Mike. And I will be honest, if we didn't have that, it would have been very challenging. But the ward-based stock, the signing off of the locally agreed protocol, the development of that, and the changes required in our electronic prescribing system were all driven through pharmacy. You must get them on board if this is the route that you're wanting to go down.
Brilliant, thanks. I'm aware that the room's going to close in a minute, but I want to get into one question and two quick responses around training and how you've kind of been able to engage people to do the training. Have you made it mandatory, or is it just about engagement? Mike, I'll go to you first and then Agechi.
Yeah. So 2 stages with the training. So the NCSCT practitioner training is for our tobacco treatment advisors. That's fairly extensive. So when we extend that, that will be targeted at smoking champions that have a vested interest in it and are willing to set in that time. So that is not mandated. But within the trust, we've embedded significant amounts of mandatory training. So we are embedded in all standard requirements for our nurses, healthcare assistants, medics upon induction, but also within our annual set training, we do a 30-minute or 60-minute update around tobacco treatment. And that is mandatory.
Thanks. Agechi?
I think so. With the NCSCT, similar to Mike, our advisors can use that to refresh their knowledge. In away days, team meetings, etc., it's been almost mandatory from ward managers for them to attend to refresh their knowledge in supporting direct and primary care. So we've kind of made it mandatory, but it is on our learning academy. So it should be in the future easy for people to just sign in, and hence why it's bi-monthly.
Brilliant, thank you. And I can see we're 43 minutes. The room is going to close in a second. What I will say is that we haven't got through all of the questions, though I can see that some of them have been picked off actually in the chat by some of the presenters. So thank you for doing that. And if there are any other questions before that people have, if you do want to add them in the chat or in the Mentimeter, I'm sure that we'll probably look to do some sort of collation and try to answer as many as we can when we send out the information, if that sounds okay.